my microphone or from that microphone?
It's from your microphone.
Mine. Yeah.
Otherwise, yeah, I mean, it's good. Is that working?
Yes, that's right. What does it have on?
The top part, yeah. We'll see how it goes.
Can we get rid of the top bar?
Click around, Command Tab, and if you switch to PowerPoint,
It's alright. Alright, we'll get started, everyone. Thanks for coming down on a Monday night. So, I'm Michael, I'm one of the fifth years. Here to talk to you about PEDS Cardio Resp, which is hopefully not the most challenging topic you'll do this year. And if it is, then yeah. When we start, at the start, I'll give you like probably the world's worst pep talk, but fourth year is a difficult year. So this year will feel like a bit of a drag and it'll feel like just the bottom right thing. But I guess the best way to look at getting through it is that, yeah, fifth year is a really good year. And as soon as your exams are finished, it is kind of like you never have to study again until you realize you don't know anything in fifth year and then still don't study. So you'll be all right. But because of that, I think you can go into this year with a mindset that you really just, you work hard, and then at the end of it, you can sort of, party. And this encapsulates my whole feelings about medical school, essentially. All right, and then after fourth year, you'll get to do lots of cool things. You'll get to go on elective, and then you'll be like, I don't know anything, and you still feel like a first year medical student, but you know slightly more. All right, we'll get cracking. So I know this is your first revision lecture for the year, and I know only a quarter of you have sort of done PEDS. Hands up if you're on PEDS at the moment. Hands up if you've looked at PEDS stuff. Hopefully all the people on PEDS have, plus some others. All right, okay. So this is just a bit about pediatric history taking. So essentially, it's all the same as your normal history taking, except for a few things. So you still run through your history presenting complaint as well as your differentials, depending on what you think those are. And you can do system review, so asking specific things about like the respiratory system or whatever. But the way I found it easiest to remember the other things that you need to ask is an acronym Big Dad. So you're looking at birth, immunization, growth, diet, so input and output, as well as allergies and development. And that's a way of ticking off all the things that don't fit neatly into your systems review or your differentials. If they're an adolescent and it's related to sort of a psychiatric or mental health issue station, then you can do a head screen, which I did a total of 0 times in fourth year. So it's not that important, but you can still learn how to do it just in case it comes up on a psych exam. And if you forget the acronym, that's a Big Dad, if you know who that is. So this is just a table of some of the key system review questions that you can ask. I wouldn't bother memorizing this, but it's here for your reference if you like asking these things in this way. So you're just with this presentation. This presentation's, I guess, reasonably complete, but you can learn pediatrics in a couple of ways. So you can learn it in a really deep way where you understand all the physiology and you know all the right questions to ask on an OSCE. Or you can study so you get good exam marks and you don't worry about the OSCE. Because PEDS is a very buzzword exam. I think the median's about 90 or high 80s or something. So you don't have to learn it in that much depth to do well in the exam, but to do well in the OSCE and to understand it is a bit of a different issue. So we'll go through things pretty quickly, but these slides are relatively complete. So if you know everything on these slides, you should know pretty much everything about PEDS Cardio Resp, apart from a few small topics I've left out. I've left out cystic fibrosis because, yeah, it was just getting too long and that's sort of multi-system. Okay, so with birth and pregnancy, you have a suite of questions that you can ask about. So this is most relevant in the neonatal period. You're not going to ask a 15-year-old all these details. But even then, I would ask, if it was a 15-year-old kid and they've come in with something, you can still ask something along the lines of, did you have any problems when you were a small child or while your mother was pregnant. You can ask that, it's not absolutely essential, but again, this is just a suite of questions you can pick from. So you want to ask about immunisations, and yeah, you can't prove a negative, but sort of you can. And then growth. So growth is a very important one, particularly for things in the early period, as well as things in later adolescent life that might be related to malnutrition type things. So you want to ask about height, weight, growth chart, and sleep. So you want to ask for their green book, which has all their growth and weight data as well. So you can ask about that specifically on an OSCE. So in terms of diet, you can split this up into input and output. And again, the questions, yeah, it just depends on what's relevant for that particular patient. But usually you would want to ask a little bit about input and output, even as brief as how's the baby's eating and drinking been compared to normal, or have they been producing the same amount of wee and poo as normal? Just even a couple of very quick questions like that, and you'll hit that off on the exam. Another thing just with sort of the pediatric OSCE specifically, this took me like 3 times to understand. But one of the things specifically on the pediatric OSCEs compared to the other OSCEs, my understanding is that they want things that are quite specific. So for particular stations, particular counselling stations, they'll want you to hit off a few very key things. And the difference for that is, whereas psych, I think my impression from what speaking to doctors is psych OSCEs are like a more holistic impression of how you performed, but pediatrics is a bit stricter and you need to hit off specific things, which makes it difficult because even if you know the topic well, if you just waffle on and don't hit the right things, you're not going to get the marks. So just something to consider with when you're practicing pediatric OSCEs, about hitting everything briefly, but making sure you hit every little single thing. So development's obviously important, depending on the station. So yeah, if it's a development station, yeah, of course, development's quite important. You can ask if the child is developing the same as any other children that family's had, which sort of is meant to, I guess, account for inter-parental variability, depending on how fast they were. Again, asking for the green book, and these are just some of the key screening questions. I'd probably try to memorize all of these. There are a few ways to memorize them, but that's outside of the scope of my talk, so I'll leave that when you get when the development people talk to you. And in the OSCE for management, this is a bit of a framework that I probably think is worthwhile memorizing, and then you just list it off and chuck in the things that are relevant to the case. Yeah, also, if you have any questions at any stage, just raise your hand. Yeah, we'll whiz through this pretty quickly just because it's quite dense, but the stuff you need to know to do well in the exams is not as dense. All right, this is not the world's greatest diagram, but it's something I found online, much better than I can draw. So essentially this is looking at the fetal circulation. It's important to understand the fetal circulation for getting an idea of why some of the abnormalities are the way they are. But again, you can get away without knowing any of this, so it's up to you if you want to listen now or you want to do something else. So during, and I'm only going to raise a few key points, not all the points. You should know some of this from year 1 and 2, maybe. So a few of the key points is you've got your foramen ovale. That's a shunt from your right atrium to your left atrium, and you've got a second shunt. That shunt is from your pulmonary artery to your aorta. So those two shunts do effectively the same thing. The objective of those shunts is because the blood that you're receiving as a baby from the placenta is oxygenated. So you don't want that blood to go to your lungs. Firstly, because the lungs are non-functional, and secondly, well, yeah, you just want it to go to your body essentially. So because of that, the baby's circulation, the fetal circulation, is designed to circumvent the lungs. And it does that in 2 ways. It does that through a right atrial to left atrial shunt through the foramen ovale, and it does that through another right to left shunt, which is the ductus arteriosus, which becomes the ligamentum arteriosum if it closes after birth. So I guess there are a few things to note. Because during pregnancy, the right atrium is at really high pressure. That's because lots and lots of blood is funneling through the placenta from the mother. And the right atrium is higher in pressure than the left atrium because the blood goes to the right atrium first, essentially. So because of that, it keeps the foramen ovale open during fetal life. But as we'll talk about in the next slide, as soon as fetal life is finished, as in the baby is born, then that foramen ovale will close. So just for your interest's sake more than anything, so two-thirds of the blood is actually meant to go through the right atrium to the left atrium, which is quite high actually. 1/3 sort of goes to the right ventricle, and most of that is meant to go down to through your ductus arteriosus to your aorta. So what happens when a baby is born and they take the first few breaths? This greatly reduces the pulmonary resistance, because instead of like fluid opposing blood flow, they now have air opposing blood flow, and it's much easier to walk through air than through water. So because of this, preferentially, the blood starts to go through the pulmonary system. It doesn't go through the systemic system preferentially. What I mean by that is after it leaves the right ventricle, a lot of it's staying in the pulmonary system, and not as much as previously. It's going to go through the ductus arteriosus. So your foramen ovale should close within the first few breaths due to this change in pressure. And the change in pressure is because now all the blood's going through to your left atrium via that circuit, and then the pressure gradient will reverse. The ductus arteriosus closes within the first few hours to days, and that's mediated by prostaglandin and indomethacin are the two drugs that you need to know about in relation to that. So prostaglandins, the way to remember it is prostaglandins prop open the ductus arteriosus, and it also makes sense if you think about it physiologically, because prostaglandins are essentially a stress response, and if you're like doing effectively sort of semi-anaerobic respiration when you're a fetus, you're going to have not as much oxygen and your body's under stress, so you'll have high prostaglandins, which props open your ductus arteriosus. After you're born, the reverse happens. So after you're born, you have lots of oxygen, the baby's not under as much stress, and then prostaglandins decreases, and the ductus arteriosus closes over the first few days. That's probably the easiest way to remember it. So indomethacin is a prostaglandin inhibitor, and it involutes the ductus arteriosus. So that's one of the medications you can use if you need to close it. So yeah, this stuff can help you with sort of visualizing the issues that happen, but it's not essential to know these. This is just a diagram of some common postnatal pathology, as well as just a good diagram of the circulation, so you can have a look at that in your own time. So congenital heart disease, 0.5 to 1% incidence, mostly diagnosed on antenatal ultrasounds at 18 to 20 weeks. Usually can't be seen before then. Well, sometimes it can be, but usually not. Otherwise, this can be things like heart murmur, heart failure, etc. So the broad classification for congenital heart disease falls into two categories. There's cyanotic and there's acyanotic. So if you remember from pre-clin, cyanotic is essentially you don't have enough oxygenated hemoglobin going around your body. So your oxygen sats are usually less than about 85%, and you don't have enough oxygenated blood being sent around the body. And if you think about how the congenital vasculature works, if you have a right to left shunt, that's going to same with the adults. If you have a right to left shunt, going from example your right atrium to your left atrium, or from your right ventricle through the ductus arteriosus to your aorta, both of those pathways are not going to go through the lungs. So the blood through both of those pathways will be not oxygenated by the lungs. So that's why they're cyanotic defects. The ones that fall in this category is the 5 T's plus H. So you got tetralogy of Fallot, TGA, and a few other ones. Probably the two most important are the first two, by far. And acyanotic are heart lesions that you don't have the problem of deoxygenation. So these are usually left to right shunt. So the blood from the left side of the heart the blood from the left side of the heart goes to the right side of the heart. So these ones that fall into this category are your ASDs, VSDs, and your PDA. Sorry, have I got these the wrong way around? No, that's right. All right. Okay. So there's this concept of ductal dependent congenital heart disease, which is quite confusing when you're starting off on pediatrics. So what ductal dependent congenital heart disease means is essentially it's dependent, the baby's life is dependent on that ductus arteriosus staying open. That's what duct dependent means. So let's take something like TGA, which can be duct dependent. It's not always duct dependent, but it can be. So TGA is transposition of the great arteries, and effectively what's happening is you've got two closed circuits. So the right heart, the blood's just going through, it's going through, it's going through. You've got your left heart, the blood's going through and keeps going through. So there's no transfer of oxygen into the blood, essentially. So in TGA, if there's no transfer of blood from the left side of your heart to the right side of your heart, then the baby's going to die because the baby's not getting any oxygen at all. So a ductus arteriosus can help facilitate that, and it can help the baby get oxygen and stay alive, essentially, by allowing blood to go, by acting as a conduit and connecting the two the halves of the heart. However, the caveat on that is in TGA, sometimes a ductus arteriosus is not itself enough to sustain life, but it's still a very good example for demonstrating what duct dependent refers to. So the other really important one is tetralogy of Fallot with pulmonary atresia. So tetralogy of Fallot, which we'll cover in a bit, you've got a few congenital abnormalities, but if you have pulmonary atresia, essentially similar things happening. Your blood's not getting to your lungs. And if your blood's not getting to your lungs, then you need a duct, a connection between the two circuits, and that's ductal dependent. So when the duct closes at around 2 to 3 days usually, around 2 days usually, then those two things, the baby's really going to struggle because they don't have any connection, or they'll have a reduced connection and a reduced blood flow between the right and left heart. So they'll have reduced oxygen going around the body. All right, so the first topic that you need to know about is tetralogy of Fallot. You will have learned about this in the first few pre-clin years, but essentially it has 4 features: pulmonary stenosis, right ventricular hypertrophy, an overriding aorta, and a ventricular septal defect. So if you want to understand the pathophys of why all this happens, essentially what's going on is ventricular septal defect is moving forward and it's effectively moving down. So the aorta is no longer sitting over an intact ventricular septum, it's sitting over both ventricles. You'll have right ventricular hypertrophy because the septum sort of moves into that musculature, and then you also have your right heart needing to work harder because of pulmonary stenosis. And you have ventricular septal defect because if your interventricular septum is moved forward and down, then there's a gap, essentially. So all these pathologies can be related back to the one thing, but you can also just remember them using like a little acronym. So tetralogy of Fallot, you'll have a right to left shunt going through your VSD, and it's associated with Down syndrome and DeGeorge syndrome. So these two associations are quite important. So you can remember it as like they fall down a lot, which also helps because they have the TET spells, which we'll talk about in a sec. And Sir George of Fallot, so he's a knight, but an Italian knight or something. So Sir George de Fallot. So in terms of the clinical presentation, most are diagnosed on ultrasound antenatally, and they might have a murmur in the 2 months of life. So the most important point to take away from this is that the onset of tetralogy of Fallot is weeks to months. It's much slower than a TGA, and that's how you differentiate between tetralogy of Fallot and TGA. So before we said, yeah, tetralogy of Fallot can be duct dependent. But if you look at that slide closely, what it says is it's a duct dependent if you have pulmonary atresia. So if you have pulmonary stenosis, there's still a bit of blood getting from your right heart to your left heart. So it's not completely duct dependent. So that's why they don't just crash at day 3. If they do have pulmonary atresia, which some of these kids do, then they will crash at day 3. But I highly doubt you'll get an exam question that's asking you to pick that. So essentially what you need to remember is the onset is weeks to months, which is what differentiates it from TGA. And it's the only cyanotic heart disease pretty much that you need to know about that doesn't present early with cyanosis. So these kids have heart failure symptoms essentially. So difficulty feeding, failure to thrive, low blood O2 saturation, and they'll have a murmur due to the pulmonary stenosis. They can also have clubbing as well, like with most cyanotic heart diseases, congenital heart diseases. So the TET spells are essentially episodes where they go into like vasospasm, coronary spasm, and because of that, the blood output is significantly reduced. And you don't need to know much about these, but what the kids do during these episodes is they squat. And the reason they squat is because it increases the return of blood back to the heart. And that helps to alleviate their symptoms. If it goes on for too long, it can lead to syncope, myocardial infarction, stroke, and death. The management of a TET spell, it's normally self-limiting, and I don't really think you need to know the management, but if you want to, then you need to intervene if it's prolonged, place a child in the knee-chest position for the same reasons as why they squat, give them oxygen and analgesia, as well as IV propranolol, which sort of reduces the spasm somehow. So in terms of the investigations you want to do, and again, like the investigations, you really only need to say these in the OSCE because they're all pretty much the same for all of them. So I wouldn't worry too much, just worry about the buzzwords. So the buzzword for this one is the boot-shaped heart. The girl who gave us a revision lecture last year had a good way of remembering this. So it's like the TOF is like a bar, like a knot or something. And then you get booted out of the TOF. So that's how you remember that the boot one is tetralogy of Fallot. They need surgical management before the age of 1 because it's a progressive disease. The ventricular hypertrophy is going to get worse. And yeah. All right. So this is, I've got a few questions listed in here, the ones taken out from the release papers. Who wants to have a go at this? Anyone on PEDS? Yeah, Gus's mate. What do you reckon? So what's happening? Why is he coming in at day 3? What happens around day 2, day 3? Yeah, is there a particular duct that closes at day 2 or 3? Sorry? Yeah, good. So what does that tell you? It tells you it's a duct-dependent lesion. Yeah? What duct-dependent lesions have I mentioned that can be duct-dependent? TGA. It's not TOF because we just covered TOF, and I said TOF is usually not duct dependent, so this has to be. Yeah, good. All right. So TGA, according to Monash, TGA is usually duct dependent. That's an important point to note. So in actual like theory, it's not necessarily duct dependent, but according to Monash, it is duct dependent. Yeah. So just keep that in the back of your mind. So what's going on here? So the baby's born well. He's doing all right, but then he's not feeding well. So he's cyano. So he's got a cyanotic heart disease, and he's got a cyanotic heart disease, and it's happened at day 2 or 3. So it has to be something that's duct dependent. Yeah, there are a few other duct dependent ones, but TGA is the main one that Monash wants you to know about. So these questions are TGA. All right. So what is TGA? We've talked about this a little bit already. So TGA is essentially where you have 2 closed circuits. So to visualize, it's just your right heart going around and your left heart going around. So in order for the baby to survive, you need to have some sort of mixing, or else there's going to be no oxygenation. So that can be done through a duct. So it can be a duct-dependent lesion, so which is a patent ductus arteriosus, or ductus arteriosus if it's not been a month, which we'll get to later. So again, as I said, so technically in real life, the PDA might not be enough. So usually they might need to have an ASD or a VSD to help sustain life. And then it wouldn't be truly duct dependent because they might be able to survive without the duct, but they'll still be in distress. So yeah, essentially it's duct dependent on Monash exams. So you have a clinical triad. So this should be highlighted in red. This is really important. Early cyanosis, single S2, and no murmur. You get a single S2 because you have with TGA, for some reason you get subpulmonary stenosis, which doesn't cause a murmur, but it does prevent valvular closure. So only A2 is closing. I don't know the deep physiology behind that, but that should be enough. They can also have a flow murmur, so that's because their heart's pumping a lot and working hard. And I guess the way to remember that there's no murmur is, well, firstly, TOF has a murmur, and TGA is like in some ways the opposite. But the main deficit is the circuits have switched. So the main deficit is not to do with their valves, so there's no real reason for them to have a murmur. All right, so the buzzword for this one is egg on a string. Yeah, it's like you eat like eggs at TGI Fridays. So it's like an egg on a string.
Michael,
Yeah.
the AMQ you put up, did it have to the testing service normal?
Yeah.
Does it take a while for the eggs in the string thing or what?
Yeah, so you don't have to have that, yeah, like with all of these things. So the egg on a string is due to right ventricular hypertrophy, yeah, which can develop in utero, but yeah, can take time to develop as well, yeah. So you can do echo ECG as well, and you want to prop open the PDA, so you'll give a prostaglandin E1 infusion. You also can do a balloon atrial septostomy, which is a temporary measure, and that's where you essentially go in and you put a balloon in the whatever there is, the foramen ovale, and stretch it open, or if it's or if it's a proper ASD, you can still stretch it open. So you need to do a surgery, like this is pretty bad if you have TGA. So you need to do surgery within the first week of life. So this is like, you really need to know this, because you don't want to be losing like relatively easy marks on the exam because you're not sure about the difference between TOF and TGA. So that's what we talked about, and I'd put that to memory. All right, so we'll move on to some of the acyanotic heart diseases. So PDA is where you have a failure of closure of the ductus arteriosus by 1 month after the estimated due date. So that's 40 weeks plus 1 month, regardless of sort of, yeah, like if they were born prem. So it normally closes 3 days post-birth. And yeah, it's used to bypass the lungs essentially. When you have a patent ductus arteriosus, the flow is from the aorta to the pulmonary artery, because the pressure in the aorta is higher than the pulmonary. So the systemic vasculature pressure is higher than the pulmonary vasculature pressure. The murmur is constant, and it's constant because the pressure difference is always present. So the systemic pressure is always higher than the pulmonary pressure. So the murmur has to be constant. It's not relying on a valve or anything like that. The risk factors, prematurity and congenital rubella. Rubella is probably one that's good to remember, and prematurity, yeah, makes sense. So PDA, there can be quite a variability in how they present. They might be just like asymptomatic for a while, but the classic triad is a prem child, because yeah, the PDA hasn't had time to sort of get the signals it needs to close. A bounding pulse with a wide pulse pressure, and that's because effectively it's like in aortic regurgitation. In diastole, some of the blood is flowing back into the heart. I know this is slightly different, but that's the way I remember it. As well as sorry, that should say continuous murmur, but yeah. In older children, they'll have the murmur can be, just remember it as a continuous murmur, but the murmur can be mainly systolic in younger children. In older children, though, it's your classical continuous machinery murmur. I've never seen a Monash question where they've said it's a systolic murmur, so you can sort of disregard that bracket. If it's severe, they'll have heart failure and all those things. So what do you want to do? Well, you want to close it, so you want to involute the PDA, so you give indomethacin. You can also give like other NSAIDs if you want. You can do a coil implantation as well, and because they're in heart failure, you can do fluid restriction and diuretics if that fails. All right, so atrial septal defect. So this is usually asymptomatic, so it's where you have a defect in between your atria, so in your interatrial septum. Often picked up on a routine exam, and it's usually like a mid-systolic, ejection systolic murmur. The reason for this is because the murmur itself, again, this is, I guess, a little bit esoteric, but the murmur itself is from flow across the pulmonary valve. So it's effectively almost a flow murmur, but it's not a benign flow murmur. It's a murmur because there's increased flow across the pulmonary valve because the left heart is chucking blood back to the right side and it has to go through the pulmonary valve again. So because of that, if you have a larger ASD, you'll have a louder murmur because more blood is going through that valve. And because of that, it's actually a systolic murmur. It's not a like a diastolic murmur. Usually you want to close it at some point. It might not be that urgent. Endocarditis, stroke, things that can happen. So the buzzword for this is a wide thick splitting of the S2. I don't really have a really good way of remembering that. Well, actually, I'll just rip off last year's lecture again. So what she said, and credit to her, but what she said was, she said like Homer Simpson is like parting his butt cheeks, widely split. So then it's like RSD. So I don't know if that helps. If that helps, that's good. I didn't come up with that one. And then the second S is the S2, so RSD, ASS2. So atrioventricular septal defect, it has a lot of overlap with ASD, and it's really not very core. There's a few minor differences, but pretty much the only thing I would really think is essential for you to know is that it's strongly associated with Down syndrome. More so than ASD. It's worse than ASD because it's like, obviously because you're having ventricular involvement as well. This one can be a bit acyanotic and a bit cyanotic, so it can have components of both, depending on the severity and exactly where the defect is. So it'll be an apical pansystolic murmur because of valvular regurgitation. All right, ventricular septal defect is a defect in the ventricular septum. It's the most common congenital heart disease. So the larger ones are the ones that are symptomatic of heart failure. The mother or the parent might complain of like all your heart failure symptoms, and you'll have a apical pansystolic murmur at your left sternal edge. So this one is different to ASD. So this one, a smaller VSD causes a louder murmur. Again, I don't think this is that important for your exams, but it's because the murmur is actually due to the turbulence. So just like in AS, AS is effectively the reverse. So as AS gets more severe, the outlet gets narrower, and that causes the murmur to increase in loudness. This is the exact same thing, except it's better when it's smaller. So because there's less blood going through. But because there's a narrow opening, there's more turbulence, so it's louder if you have a smaller VSD. And you get heart failure as well. So a typical EMQ is what it is just down there. So that's kind of what we talked about. So yeah, do an echo as with all of these people. The small ones often resolve spontaneously, but of course, if they have like really bad heart failure, you probably gonna need to do surgery. Otherwise, you can just treat their heart failure, diuretics, ACE inhibitor, etc. Dental hygiene as well to prevent bacterial endocarditis because it can lodge on any sort of defect within the within the heart. And you can also do echoes to keep an eye out for any left ventricular hypertrophy. So we'll look through a few other conditions now. How are we going? We'll try and get you out of here by 7:45. We'll see how we go. So PFO is a failure of the foramen ovale to close after birth. So this is a little different from an atrial septal defect. There's some like deep explanation, but I don't really know it. Essentially, the explanation that is easiest to understand is that a PFO is just the foramen ovale is open. It stays open. An atrial septal defect is where you actually have like a big defect or a defect that shouldn't be there. So the patent foramen ovale, the main thing you're concerned about, because it's not like an actual defect, it's just this hole is open that shouldn't be open. It's not like ripped open or anything or larger than it should be. The main issue that you have is paradoxical stroke from DVTs, where it just goes straight through to your brain. So from your veins through to your heart, through to your coronary, carotid arteries. Usually you don't really need to do anything urgently. You can give aspirin if you're worried about stroke. Usually you'd want to close when they get a bit older. Yeah, that's all you need to know. So Eisenmenger syndrome, this is probably not particularly accessible, and if it does come up on exam, it's pretty easy to pick. Essentially what's going on is they have something like a VSD or an ASD where the blood's going from left to right, but then because of that, there's more fluid in the right. Eventually, the right heart has to work harder and harder to accommodate for that. It hypertrophies, and then that can eventually cause a right to left shunt. And suddenly, when that reversal happens because of the pressure difference, the patient can become very cyanotic. That's very severe, very poor prognosis, and you need to transplant things. There's a few benign murmurs I think are worth knowing. They're not explicitly taught, but I do think they're worth knowing. So yeah, I would know them. So Still's murmur is a benign systolic murmur at the left sternal border, which has a humming or musical sounding quality. Oh no. Fuck. All right. I'm not going to be able to get rid of that, am I? We'll just leave it up there for a moment. So coarctation of the aorta is, wait, sorry, what are we? Yeah, so there are a few diseases that we'll talk about now that are essentially outflow obstruction. So you've got coarctation of the aorta, aortic stenosis. The same things occur in adults. They're just, they're essentially the same in peds. They might be slightly different. So coarctation of the aorta is where, usually due to the duct closing, it causes coarctation, which causes a outflow obstruction. So this is interesting. It's sort of duct dependent, but it's not really. It's not duct dependent in the way that the others are. It's duct dependent because the coarctation happens when the duct closes. So because of that, it can be sort of classed as a pseudo duct dependent lesion. But it's not actually the duct that's, yeah, it's different because the blood flowing through the duct is not what's making it duct dependent. It's the constriction that happens when the duct closes that's making it duct dependent, if that makes sense. So yeah, they'll have cyanosis shock at day 2 to 3 when the duct closes, and they'll have all your normal aortic coarctation things. Rib notching, echo, and you give them PGE1, so even though it's closed, it might not be fully closed, but you try and prop it open. Aortic stenosis is, I might actually get rid of this, I'm not. Aortic stenosis is essentially the same as it is in adults, but it's usually due to a congenital deformity such as when they're fused together. So it's usually asymptomatic. They might have a murmur. If it's severe, they'll have syncope, angina, dyspnea, like when they're an adult. You can do a balloon valvotomy, just like stretch it open, or you can do valve replacement later on. Pulmonary stenosis, the important thing for this one, it's associated with Noonan syndrome, and Noonan syndrome is most strongly associated with pulmonary stenosis. Noonan syndrome is also associated with TOF, but not as strongly. All right, these are just your things of heart failure. So it's a bit different in kids as opposed to adults, but that's because they can't communicate, they're not doing exercise, so it's all pretty self-explanatory, really. This slide I would memorize like fully, if you can. Yeah, it's all pretty self-explanatory. We've talked about most of them. Alagille syndrome is some weird, like, hyper growth thing where you get like butterfly vertebra, you get like extra growth in your liver and stuff like that. And for some reason it causes pulmonary stenosis and tetralogy of Fallot. So these are, again, some benign pediatric heart murmurs. Not going to go through these in the interest of time, but yeah, you should probably know at least Still's murmur and peripheral pulmonary stenosis and venous hum. Yeah. All right. So that's cardio. Do we have any questions? Anyone got any questions about the cardio stuff? We'll go through a few questions later on. No. Is there actually any way I can get rid of? Is there any way I can get rid of that update scene? Or is that just not going to happen? Why does that go away? Do you know, Jen? Oh, no. Sorry? Okay, whatever. All right, so Pete's resp is probably more challenging than Pete's cardio. I'd almost say Pete's resp is the most challenging Pete's thing. The reason for that is lots of the things in Pete's resp, some of the things in the exam are not as cut and dried, particularly with asthma management. So we'll go through a few of them. Most of it's pretty easy though, like Pete's is not that hard. So it's not that hard on Monash exams. So I think, like, yeah, Rupert Hines, the guy who writes the exams, he says the PEDS exams are designed to essentially see who should fail rather than see who's a good student. So yeah, that's why they're easy. So yeah, these are some of the conditions we'll talk about. Just to note, stridor is an inhalation noise and wheeze is an expiration noise at its most simplest. That's not completely true, but it's just easier if you just understand it that way, probably. If you're interested, I can explain it after the lesson why it's not, after the lecture, why it's not exactly true. But I spent like 2 hours reading it and then it was never useful, so yeah. Anyone want to have a go at this one? Yeah, how do we know it's croup? Yep. What about stridor? Is that typical of croup? Yeah, cool. What's the other name for croup? Cool. All right. So croup is laryngotracheobronchitis. So it's inflammation of those three components. Inflammation of the larynx causes a hoarse voice because the larynx is where your vocal cords and stuff are. Inflammation of the trachea, it causes stridor because it's like an upper airway thing that causes stridor. And inflammation of the infection, inflammation of the bronchi causes that barking cough. So you can remember the features by splitting up the name, which can be handy. It's caused by parainfluenza virus most typically. You need to know that. The classic age, you need to know this as well, is 2 years, age range 6 months to 6 years. Your risk factors are smoking, prematurity, instrumental things. We sort of talked about this. It can be preceded by a viral prodrome. The symptoms can be worse at night, but they're usually not too unwell. So usually it's a clinical diagnosis. You don't really want to examine the throat if you can avoid it because it can upset the child and like cause obstruction and things like that. If you do a chest X-ray, which you'll probably never do unless you're concerned they might have, I don't know, like a fracture or something, they can have subglottic narrowing, which is essentially because of the tracheobronchitis, so the tracheitis essentially. So it's inflamed below the glotti. O2 usually normal and chest is usually clear. So the management for croup is reasonably simple. So I think Rupert Hines thinks there's something called nebulized prednisolone, which there may be, but there's not on ETG. So the exam answer for these will be nebulized prednisolone. But really what you should be giving is either prednisolone, or you can actually nebulize prednisolone, but it's not commonly done. No, well, not according to Rupert Hines. But yeah, and that's all that matters in the end. They probably do. I don't know. I never went to pediatric hospital. So no, I did. I'm just joking. So yeah, prednisolone is usually oral. It can be nebulized. I think that the nebulized I've written there because Rupert Hines says it's nebulized. You can also give nebulized adrenaline if it's severe, and if they're really severe, you might intubate them, but that's hard because it's a hard intubation. But usually it's not too bad, and it's not like epiglottitis where they might die, usually. So you admit like all of these if they're in severe respiratory distress. Foreign bodies where they've swallowed a foreign body. Usually it's not food if they're neurologically normal. So if it is food, apart from like if it's like soft food, usually they're not neurologically normal. Not a really major point, but yeah. Usually, so acute stridor shortness of breath, chest X-ray might show something with a hyperinflated lung on the other side because one side's obstructed, it can collapse, the other side is overused, so it's overinflated. And you need to do a bronchoscopy to get it out. I know this sounds quite simple, but when it comes up on exams, when it comes up on some of the release papers, it can be a bit sort of, it's not as obvious as you would think. So just always think about foreign bodies. The acuteness is really the thing that makes you pick foreign bodies. All right, anyone know what this one should be? Gus, what do you reckon? Yeah, good. Why?
Because so the question makes you need
Okay. That was a great explanation, you guys. So if you think it's TB, it's acute epiglottitis. Okay. All right. Well done. So do you know what organism causes acute epiglottitis? Or, yeah, Haemophilus influenza B. So that's one of the things that's regularly vaccinated in Australia. It's not in other countries. So usually if you're unvaccinated, well, usually the kids will be unvaccinated and they'll give them a much higher risk of acute epiglottitis. They can also have increasing problems breathing as well as high fever. This is the bad one. So this is, croup is like, yeah, croup is usually okay. This is usually quite severe. So it's caused by inflammation of the epiglottis, which is just the little thing that sits over the entry of your trachea and larynx, and that region. It can cause complete airway obstruction if it swells too much because of the location, as you can sort of see in the laser. As you can sort of see in the diagram. All right. So in terms of pathophys, so yeah, the swelling will cause an inspiratory stridor because the air, like if it's partially occluded, the air's trying to get in. So it's going to be worse when the air's trying to get in. When you're breathing out, that's going to actually push out the epiglottis. So that's going to make it a little bit better. So that's why you get the inspiratory stridor, but no expiratory wheeze. Children, they'll have difficulty swallowing because of the inflammation, because they can't, because during swallowing it actually involves the larynx in that region as well as the hyoid bone. But because of the inflammation, they don't want to do that and they can't do that. And that leads to drooling and absence of cough as well, because for the same reasons. Usually it's in young children, so 3 to 12 years, and it's very rare due to immunizations. So they'll have dysphagia, drooling and distress, so the 3 Ds of acute epiglottitis, as well as stridor, and they'll be quite sick. And the absence of cough is another big buzzword. So all those things in bold and underlined, I would remember. And if you see those in an exam question, you'll probably see all of them, and then it's, you know for sure it's acute epiglottitis. If you see they're not vaccinated as well, which is, yeah, like if they, I think nowadays they sort of hint like the hipster areas like Brunswick are unvaccinated areas. So if the child is upset or crying, then they can have a complete airway obstruction. So that's why you want to try and avoid examining the throat. All right. This will have a thumb printing sign. Again, not too important. I highly doubt you'd be asked to differentiate croup and acute epiglottitis based on X-ray. So that's a buzzword you can remember if you want, but you probably don't have to. The management is different to croup in that for croup it's more of like a viral picture which causes inflammation. So you want to reduce the inflammation by giving pred. You want to open up the airways. Whereas in acute epiglottitis, it's a bacterial infection, so you need to get rid of the bacteria. You use IV antibiotics like ceftriaxone as well as DEXA to help reduce this swelling. And prophylaxis for other people in the family is rifampicin. I don't really know why they use rifampicin exactly, but that's, well, I guess because of studies and evidence. But yeah, apart from that, I don't know why. But that's an important thing to remember as well. Again, this is another really important differential. So these two you have to be able to differentiate on the exam. These are all the things we sort of talked about, but it's all summarized here. So you can read these, and I would like memorize these 100%. Bacterial tracheitis is essentially croup plus. So remember, acute epiglottitis is already pretty bad. So you're not going to have acute epiglottitis plus. So your croup is not that bad. So you can have croup plus, which is bacterial tracheitis. So croup plus is where you get the symptoms of croup in bacterial tracheitis, but you also get a very sick, very toxic picture, which is more like what you would see in actually like acute epiglottitis, but the clinical symptoms more aligned with croup. So what you need to do is you need to secure the airways so you can tube them or whatever, and they're not going to respond to croup therapy, so you pred and adrenaline, and you need to give them IV antibiotics. So to differentiate acute epiglottitis from bacterial tracheitis, so acute epiglottitis, they'll more emphasize the like dysphagia during distress, as well as the as well as this little absence of cough, which they won't emphasize as much in bacterial tracheitis, essentially. Subglottic stenosis is what it sounds like. It's stenosis underneath the glottis, so underneath your vocal cords. It's caused by essentially long-term ventilation, mostly from like, obviously intubation would be the main one, but any ex-preterm infant with long-term ventilation is the classic type of stem you might get, and it will give you an inspiratory and expiratory wheeze, because the wheeze is sort of fixed on the walls. It's stenosis, so whether the air is coming in or out, it's not going to affect how loud it is, because it's not an up-down flap. It's like a side narrowing stenosis. So the wheeze is both inspiratory and expiratory because of that. All right. Anyone know what this one is? Any ideas? If you haven't, yeah? No? Yeah, good. Why is it H? Yeah. Good. Do you know if laryngomalacia is more, actually it sort of says that, but yeah. Do you know if there's an inspiratory or expiratory noise? What was there for laryngotracheal bronchitis group? Was it an inspiratory or expiratory noise? Inspiratory. This is the exact same, well, it's not the exact same thing, but it's the same principle. So there are two types of malacia in children that you really need to know about. One's laryngomalacia, the other's tracheomalacia. The way to remember the difference is you can remember it and relate it to croup, laryngomalacia if you want. You can also remember it as that the larynx is above the larynx is essentially like above the trachea. So the larynx is like all that soft tissue type of stuff. And when you breathe out, it helps to force open those tissues. So the airway is not going to be really occluded. But when you breathe in, that doesn't happen. So you're going to have inspiratory noises. Whereas in tracheomalacia, it's the exact opposite. So in tracheomalacia, it's just like in asthma, how you get an expiratory wheeze. It's a bit different, obviously, but that's how I remember it. The trachea is closer to your bronchi and bronchioles, and that's where asthma causes an expiratory wheeze. So tracheomalacia is an expiratory noise. You can also remember it as laryngomalacia affects the same things as croup, which is an inspiratory noise. So malacia just means something in the tissues. It's not that severe. You won't need to know much about this, but you might need to pick it. So you might need to diagnose it, as we talked about.
Why does it change the sleeping itself?
Um,
Like the amount of airflow? Or is it positional?
I think it's to do with how much. I think it's to do with how they use their muscles, I believe. Yeah, I don't know any more than that, but I think that's why. So when they're crying and upset, I think that results in like a bigger occlusion effectively around the larynx area. All right. Anyone know what this one is? Any ideas? If you're on PEDS, you should probably know what this one is. You probably see it every day. Yeah, good. All right. So bronchiolitis is like it's just a baby urti, sort of. So they have a mildly febrile baby. They're usually not too bad. They'll have cough, bit of shortness of breath. They'll have widespread wheeze and crackles. The other thing, the way to think of it is, it's like childhood. It's like baby asthma. How does that work? They don't really know, but just like in how asthma can be triggered by viruses, bronchiolitis can also be triggered. Well, is caused by viruses. There's sort of this thing called like viral-induced wheeze, which is for when they're about 3 to 5. But don't worry about that. That's when they don't want to call it bronchiolitis and they don't want to call it asthma, essentially. But they should call it asthma technically. Yeah. So it's a it's a viral urti, not urti, lower respiratory tract infection, and it occurs most commonly in the really young kids, so less than 6 months and up to 2 years. But after 12 months, there's an overlap with asthma. It's caused by a respiratory syncytial virus, which again you need to know, and yeah, risk factors, young age, etc. So the course of bronchiolitis, they can have a coryzal prodrome, like with any sort of viral thing. They might have a brother who's got an urti or lurti, and it gets worse until about day 2 to 3, which is important for knowing when to admit or admit a child with bronchiolitis. So if you've got a child with bronchiolitis, they come into hospital because the parent's concerned. They're a little bit bad, but it's day 4. You're not going to keep them in hospital. If it was day 1, you probably would, because you know they're going to get worse over the next 2 days. Yeah, widespread wheeze, so expiratory wheeze, and they'll have poor feeding as well. Just increased work of breathing, as well as they can have dehydration from poor feeding. So bronchiolitis is usually clinical diagnosis, don't really need to do anything. Again, it's a viral thing, so you're not really going to do anything. You can try bronchodilators. There's not much evidence for that, and it doesn't, probably won't do that much. You want to give them small feeds, as well as you can do a NGT if you need to. The small feeds is just to, you know, they can't do big feeds when they're sick. So the only reasons you would admit for bronchiolitis is if they need O2 supplementation, if they need fluid supplementation, or if they're a high-risk patient. So that means a few things. That means if they live far away and they're sort of bad, or they're at day one. If they're at day one and they're already kind of bad. It doesn't mean if they're moderately bad and they're at day 4. Then you should send them home because they're over the worst. If they're having lots of bronchiolitis, you can give them palivizumab, which is an RSV monoclonal antibody. It's very, very expensive, so it's not done very much. And yeah, it can be done for high-risk babies as well. So as we talked about, poor oxygenation as well as poor feeding, and if they're high risk, so if they live far away, they're not coping, or if they're at day 1 and they're probably going to get quite bad. Whooping cough you'll have done as it was our first PBL ever, I think, so you have good memories of that. So it's caused by Bordetella pertussis, which hopefully by now you know is a bacteria. The most commonly affected age group is actually adolescents and young adults. That's probably something to keep in the back of your mind. But when it affects kids, it is much more serious. So if it's less than 1 year old, the high mortality, I think it's about 50% or so, or a bit less than that probably. And it's transmitted via droplets. They're contagious for 3 weeks after the cough if they're not treated. And there's an incubation period of 7 to 10 days. So if you ever see like vomiting plus cough, it's pretty much always whooping cough. They'll have a paroxysmal coughing fit, and then they'll have like a whoop at the end. So I didn't put a video in here, but you should be able to find that on YouTube pretty easily. There's a prodromal phase, then the paroxysmal phase, which is the phase you typically hear about. They'll have the whoop and the attacks, and then it subsides. They can have a cough for weeks to months afterwards. Again, it's usually a clinical diagnosis. There's one of the questions on the release papers where it's like, oh, do you need to do a PCR or not? That one's a really vague question, which no one really knows the answer to. The answer is probably no, but the main reason you would do a PCR is for epidemiological purposes. But that question, yeah, I can't remember the exact question. I didn't put it in here, but if you have a question about that later on, you can send it to me and I'll look up what I thought at the time. But essentially, the answer is probably no, maybe yes. So yeah, you don't really need to do anything else. For management, so whooping cough can be a very common sort of OSCE station because the management's quite difficult. There are quite a few things to remember. So you need to remember if it's a notifiable disease. You need to remember to admit to hospital if they're less than 12 months or if they're severe. Antibiotics is useful if given early, less than 2 weeks. And you need to know that exact 2-week thing. I'd look up ETG for the exact timing of this. This is like a good summary, but if you really want to know the exact details, have a look at ETG. The reason for that is you need to isolate them until 5 days of therapy or they've been coughing for greater than 21 days. At 14 days, if the medication takes 5 days to work, you're only saving 2 days essentially, or maybe 1 day because you need to get the medication or whatever. So essentially there's only a benefit if it's given under 2 weeks. You use azithromycin or clarithromycin, and you also can give vaccinations to contacts as well as antibiotics, so macrolides. There's quite a few complications, don't really need to know them, just bad things. Pneumonia is probably the most important one. So the vaccinations for this are relatively important. They're there. Vaccinations are really hard to learn the dates, but it's not that important. Pneumonia is very similar to what you did in 3rd year. There's just a couple of small differences. So in kids, it's most common in children less than 5 years old. There's a list down the bottom of what pathogens occur in what age groups. You probably don't need to be too concerned about this. Viral is more common in young children, so looking about under the age of like 1 to 2 to 3. Bacteria as they go to sort of 5+. In under 1-year-olds, the most common bacterial is Staph aureus and strep. I wouldn't remember the table down the bottom unless, yeah, just remember it roughly, I'd say. Yeah, so symptoms and those things are exactly the same as adults, as well as poor feeding. Investigations exactly the same as adults. Essentially, you can do, just the same things as adults. So again, most managed at home. I don't really think Rupert Hines looks at any particular scoring systems, and I don't think there's ever been a question about whether you need to manage them at home or manage them here, at least not on the release papers, which are the only questions we have access to, of course. For your admission, if you are admitting them and if they are sick, then you can give them O2 if they have low oxygen sats, and as well as antibiotics for 3 to 5 days, according to the literature, but in real life they often do 5 to 7. So the empirical is Ben-Pen as well. So one of the doctors was like, you should ask about pleuritic chest pain, because pleuritic chest pain is actually a feature of pneumonia, even though you don't think to ask about it. And in terms of the management, yeah, you just want to manage the complications, so antibiotics, chest tube drainage. You can do VATS, which is video-assisted thoracic stuff, so if they have an empyema. All right, does anyone know the answer to this one? Or does anyone want to? This one's not that easy. So as I said, some of the asthma stuff is a bit difficult. Anyone want to give it a crack? F. Yeah, F's not unreasonable. Why do you say F? What buzzword? Okay. Like a specific question, or? Oh, okay. Yeah. Okay. That's not the correct answer for this one. It is a reasonable answer, because sodium chromoglycate is used in young kids as a preventer, can be used. So sodium chromoglycate is chromone, which is a mast cell stabilizer. Any other guesses? See, yeah. So you probably wouldn't go on the combo straight away. Yeah. Anything else? Sorry? Yeah, A. Yeah. So A is the correct answer for this one. Nate, did you say A? Yeah. Do you want to explain why you think it's A? Yeah. Okay, that's pretty good. So the first question you need to ask yourself is: Does he need a preventer? You need a preventer if you're having persistent asthma. So we'll talk about these categories. But if you're having persistent asthma as a kid, you need a preventer. If you're having like frequent intermittent asthma, you may need a preventer, depending on how you're going. And this is actually quite complicated. Like knowing the exact guidelines for when to use a corticosteroid versus montelukast versus chromone, which is sodium chromoglycate, is actually quite complicated. I haven't gone into that in too much detail, just in the interest of time. But essentially, the rule of thumb, which applies for 0 to 5-year-olds and 6+, even though there's slight differences, is if they're mild to moderate, the first preventer you want to try is montelukast. If they're moderate to severe, the first preventer you want to try is a inhaled corticosteroid. So that is just a very broad rule of thumb. And of course, that doesn't help. Like, what if they're moderate? Then what do you do? Then you look up the guidelines, so moderate actually is different between 0 to 5 and 5 plus, which is why I haven't talked about it here, just because I think it's easier for now just to go by those general rules of thumbs. The Asthma Management Handbook, though, it does have a it's not succinct, but it's like in a few different places, but it's succinct, but you have to look at a few different places. So if you want to, I would look at that. Otherwise, just go by those rule of thumbs. So I would say he's probably moderate to severe, because he's getting some nighttime symptoms. It's not every week, but it's sort of pretty bad. And he's getting daytime symptoms more than once per week. So I'd say it's leaning on the severe side of moderate. If you look at the exact definitions for this, you will find that the answer is budesonide inhaler. But those rule of thumbs for a question like this, they'll have you in good stead. So yeah, Chromone is the other option. Chromone is not recommended apart from the 0 to 2 age group. But even in the 0 to 2 age group, it doesn't have enough evidence for them to recommend it over Montelukast. But it can be used as an alternative to like a Montelukast in the 0 to 2 age group. So childhood asthma, yeah, reactive airways disease, chronic inflammatory disorder. It's the same thing as you've learnt about for multiple years. Symptoms are the same. These are a few questions that you can ask as a sort of a suite of questions that help you to determine how severe other symptoms are. In terms of the triggers, respiratory tract infections for kids is the most common by far, whereas in adults it might be more sport or more sport. I would know this, not off like by memory, but I would know this so you can have a pretty good shot of putting them into one of these categories, because it does affect your management. So the important things to note are the oxygen sats, as well as if they have reduced consciousness, they're immediately life-threatening. If they have cyanosis, they're immediately life-threatening. If they have poor respiratory effort, immediately life-threatening. And then mild to moderate and severe can just be sort of common sense, I guess. So in childhood asthma, the response, the management is determined by the pattern of disease and not the severity as such. So so there's episodic and persistent asthma. Episodic asthma is can be classified as infrequent or frequent. So frequent less than 6 weeks apart, and infrequent greater than 6 weeks apart in terms of when they have like exacerbations. So these are a few diagrams that just sort of demonstrate that. So infrequent episodic asthma is 65 to 75%, so the majority. The episodes are greater than 6 weeks apart. There's no interval symptoms, and they should have normal lung function tests in between those times. Preventative therapy is not indicated under pretty much any circumstances. Frequent episodic asthma is responsible for about a quarter of cases. So it's attacks less than 6 weeks apart. They may be more troublesome, and they're often sort of seasonal symptoms. Persistent asthma is when you have symptoms between attacks. You have symptoms most days. You might have abnormal lung function tests between attacks. They're using the beta agonist more than 3 times a week, and they can have interval symptoms even between attacks as well. So you can use a preventer for both persistent asthma as well as frequent episodic asthma. You don't have to in frequent episodic, but you can if they need it. You don't want to do spirometry in a young child like 2 years old. You don't really want to do it until they're 5 because it's very effort dependent. So if they respond to a bronchodilator, they clinically improve. That's how you sort of diagnose it, I guess. But that is also why there is a suspicion of overdiagnosis of asthma because of that. But, oh well. So the acute management of asthma and the chronic, so the acute management of asthma, you need to know really well. You need to know sort of off the back of your hand for both exam questions as well as for a potential OSCE station. So firstly, you want to classify it into a category. So you want to say, after doctor's ABCD, you want to say, is it mild, moderate, severe, or life-threatening? Give them oxygen if they're at less than 95%, not if they're over 95%. There's no point to, and oxygen's a drug and it can cause side effects as well. In terms of bronchodilator, it's not your 5, so your 5 by 5 rule or whatever it is, 4 by 4 by 4. That rule is for like public members to use in first aid situations. It's not for doctors to use in life-threatening situations. So, or even for doctors to use in public situations. Yeah, it's just because 4 by 4 by 4 is easy for the community to remember. That's literally the only reason why they say that. But what you want to do is if they have mild to moderate, you can go straight up to 12 puffs and just hit them with that if they're over 5, depending on how severe they are. If they're severe, you want to hit them with definitely 12 puffs. And the only reason you use a nebulizer if they can't breathe through a spacer. So a spacer is the same effectiveness as a nebulizer if they can breathe through it. And then you can repeat salbutamol at least 3 doses in the first hour, so every 20 minutes or so. If it's life-threatening, you can give 10 milligrams on the neb, and that's because if it's life-threatening, you're assuming they're not going to be able to use a spacer, which is a fair assumption. If they're 0 to 5, then you just halve the doses. You want to reassess at that point, and then you can consider adjunct therapy. So these things, there's no really strict guidelines about when to use each one exactly, so that's why it can be a little bit hard for exam questions. So ipratropium bromide, you can give less than 4 puffs if they're under 6 and 8 puffs if they're over 6. You can use oral pred as well, but oral pred's not going to help that acutely. It will help over like the course of like 30 minutes to an hour or so, I guess. And you can also use various IV therapies. So out of these, the most common ones probably magnesium sulfate and aminophylline. You can also use methylpred and IV salbutamol, but there's not as much evidence behind salbutamol. You want to try and avoid oral pred in a preschooler because it hasn't been shown to help that much, and even for short doses can be, even for once-off doses can be damaging. And yeah, salbutamol excess can cause those things, which you should know from last year as well. So for regular chronic management, it's sort of similar to in adults. There's a few slight differences. As we've talked about, for the hardest thing to determine is the preventer. So if it's mild to mod, sort of give montelukast. If it's mod to severe, ICS. If you want to know exactly when to give for different age ranges, look at Asthma Management Handbook. So mostly they don't need maintenance therapy. Only persistent definitely needs it, and frequent episodic you can use it. So yeah, the rest we sort of talked about. And then you step up to combination therapy. Never use LABAs by themselves. They're associated with death, of course, and oral corticosteroids. I think that it's been shown that they have, if you use them from when you're young, then you get like I think it's like 2 centimeter height loss, something like that. Which is a significant amount, depending on how tall you are. If you're shorter, it's probably more significant. So that's just stepwise approach from ETG. And this is just some stuff really for your reference. I won't go through all of this stuff. But it's just like how to take salbutamol, which can be a counselling station. Yes. So asthma management plan is very important to mention in the if it was an OSCE station. All right, we'll go through a few EMQs. There's only 4 slides, but I think some of them have like 4 questions on them. They're all from the released papers. These ones are pretty important. Maybe I'll just pick on people. Elaine, do you want to have a go at 54? So just talk me through your thinking, even if you haven't done PEDS. Any ideas? Or even if you don't know, just what do you think? So-
we've been given oxygen.
Yeah.
And he's already had steroids.
Good.
And nebulizer, so it's
Good.
nothing more. And it's been classified as severe.
Good.
So he doesn't have infection on pneumothorax, so we give like the antibiotics. So it's really
Yeah.
out.
There's a few options covered on the screen, but hopefully you can see it on yours. Yeah.
Yeah.
What about neb corticosteroids?
Yeah, I was thinking of that because you said it, but I don't know.
So he's already had the IV steroids. So yeah, So after you've failed all your first line therapies, then you go to your adjunctive therapies. He's already had where is it? So A is a potential good option because ipratropium bromide is one of your adjunctive therapies. So essentially, the way to look at this question is he's failed his adjunctive therapies. What's next? Yeah, ipratropium bromide on that slide, that was one of your next options. Why would you not go to inhaled ipratropium bromide on this patient? Yeah, he can't breathe. So he's already on nebs. So you should never, unless they're like stable, you should never bring someone back from nebs to inhaled. So if you stop the nebs and you're making him inhale stuff, he's not going to be able to breathe it in, firstly. And secondly, he's on nebs. So I wouldn't take the neb mask off for a bit just so he can try that. So if it was neb ipratropium, I might select that as the answer. But in the absence of that, you look for your other adjunctive therapies. So F is intravenous mag, which is one of the other therapies. He's already got an IV line, so that's your best answer for this one. Essentially, you just go down that chart. You just go down the stepwise process, and if he doesn't have anything, then if it's not improving, you go to your adjunctive therapies and see what's there. 55, Lindy. What does this girl have? Croup, yeah. What do you give for croup? Yeah, what did we say Rupert Hines likes to give? Yeah, which is G. All right. 56 is pretty easy, and 57 is pretty easy as well. So we can skip those. The questions like 54, those are the hard asthma questions. Those are probably the hardest questions you'll get because they're not completely buzzwordy questions, I guess. These are just some of the cardiac stuff. Samir, do you want to pump out all four?
Alagille syndrome is going to be probably pulmonary stenosis.
Yeah, good. If it wasn't pulmonary stenosis, what's the other one associated with Alagille? Yeah, good. Oh yeah, also so Noonan and pulmonary, like Noo sounds like poo, so that's how you remember that one. Oh, that's true as well. Yeah.
10-day-old baby is crazy preterm. They have PDA. 72 question. 2-day-old cyanotic baby, no murmur is the transposition.
Yeah.
And acyanotic. Poor feeding is a VSD buzzword.
Yeah.
That gets the
Yeah, good. Good. All right. Any questions? So for question 71, so 71's a bit unusual. I remember doing this last year, and a few of us were discussing why they're suddenly getting worse at 10 days. The answer is we don't really know, but we couldn't figure it out actually. But a prem baby and everything else fits with PDA. So and it's also not technically a PDA because it hasn't been a month, but discounting those two things and also accounting for the fact nothing else makes any sense, the answer is PDA. Yeah, I don't know why that's getting suddenly worse at 10 days. We tried to look up all these reasons, but we couldn't find anything. But if anyone knows why, let me know. Any questions about the other ones? No? Yeah, 72 is TGA, yeah. All right, and that's done. Good luck for the rest of fourth year. I know it's a long year, but you'll get there. And if you have any questions, just come down now and you can ask me. No worries. That's all right. That's all right. All right. I'll just close this here.
Yeah, I think so.